Good afternoon, one and all. Today, we have gathered here for a workshop which is much needed. That is the competence by design, entrustable professional activities, milestones, mapping, and assessment. By the word itself, we know that it is going to be tricky, entrustable professional activities. I know that this is the first time the word we are hearing, but we have the newly framed curriculum of the Dental Council of India, which gives us this freedom to assess our students based on these frameworks. Now, to understand this, we have the speaker, Dr. Andaleeb Arshad, who's the Director at Faculty Development, Kuwait Institute of Medical Specialization, Ministry of Health, Kuwait, who has accepted to be the speaker for this today's program. With this brief introduction, I request all the vice principals and the Deputy Director, Enopaya Dental Education, Enopaya Center for Faculty Development, and chief guest of the day, Dr. Ashita Opur, to occupy the dais. So, ma'am, Vidya ma'am, please. All the vice principals, ma'am. I request Dr. Junaid to give the invocation.
Good afternoon, everyone. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم. مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم. صراط الذين أنعمت عليهم غير المغلوب عليهم ولا الضالين. آمين. صدق الله المولانا العلي العظيم. Thank you.
Thank you, Junaid. Now I request the Deputy Director of Enopaya Center for Faculty Development, Dr. Abhay Nirgude sir, to give the welcome address.
Good afternoon, everybody. So respected dignitaries on the dais, faculty members, the guest speaker and the chief guest of the program, very good afternoon. Firstly, I would like to thank Dr. Imran Pasha for organizing this activity on behalf of Enopaya Dental Education Unit and Enopaya Center for Faculty Development. I would like to welcome the chief guest of the program, Madam. Very happy to know that Madam also done the graduation and post-graduation from Mumbai. So we are happy to have you, Madam. Our Dean, Dr. Akhtar Hussain sir, always one step ahead, Dental College, in taking any initiatives. DCI has introduced this and Dental College is leading in organizing such events. So welcome you, sir, on behalf of Dental Education Unit and NFDC. The Vice Principals, Dr. Shambhat sir, Dr. Majijos Madam, Dr. Chatra sir, Vidya Madam, and all faculty members. And more importantly, the guest speaker, Dr. Andaleeb Arshad, because we are looking for somebody who has already worked and implemented this CBME as competency-based dental education. And we are very fortunate to have Dr. Andaleeb Arshad as who is a Director Faculty Development from Kuwait Institute of Medical Sciences. On behalf of Enopaya University, I welcome you, sir, for this program. Just few words about why we are gathered here. As we know, what is permanent in life is change. Everything will change, but the change is permanent. And the change which has come in the form of reforms in curriculum is always, we don't have any choice, but it has come for a good cause. So there are gaps. That's why curricular reforms are essential. And first thing, when as a medical faculty, when CBME was introduced in 2018 and 19, it has started implementing. We have gone through this process of accepting the change. And first thing what we have to do is, as a faculty, is we have to accept that, yes, this is the change and I want to be part of this change and I will lead the process of this change. So then we could able to implement this program in full spirit. Now, with CBME, we are practicing, we are doing it. We are actually practicing what is EPA, Entrustable Professional Activity, competencies. We are actually going through this process, but we are not practicing it as a proper structure, well-defined competencies. But whenever any complex case come, we'll see that who is on call. Okay, Dr. Imran is on call. So complex case, he will handle that case. So that trust we used to have, that we used to entrust, yes, he or she is on call, that work will be done. So he or she is very good in doing that particular task. So he or she will manage. That is what is an entrustable professional activity. So when you want to recruit any faculty, or you want to recruit somebody for your clinic or hospital, we will see that what is the task the doctor supposed to do. We'll enlist that. And accordingly, we'll try to see what are the competencies the interviewer person should have. So we'll try to match the expected entrustable professional activity supposed to be done, the task, and the competencies what the person is possessing, that competencies. So this is, we are practicing it knowingly or unknowingly, we are doing it, but we need to have it is a full framework. We have to define it, how we are going to do it. Already the guidelines have been given, but I only think the challenge for as a college or institute, what we may face is first accepting the change and being part of it. I don't think NPI Dental College will have this issue, because always we have done so many initiatives we have already undertaken, and that is rest assured. Second challenge is the resources, the trained manpower, the resources, the time, and the logistic required. So that we have to work out, and I don't think there will be any challenge. So this is a great beginning to as a capacity building of the faculty. So I wish all the best for this session. Thank you.
So thank you for introducing us the entrustable professional activity. Now we move on with lighting of the lamp. I request all the dignitaries to come forward for lighting of the lamp. Now I request Chief Guest of the Day, Dr. Ashita ma'am, to address both the online as well as the offline attendees.
Good afternoon, everyone. The Dean of NPI Dental College, Dr. Akhtar Hussain, Dr. Nirgude, your NPI, I think the faculty coordinator for your FDP programs, and we have all associate deans, Dr. Majji, Dr. Chatra, Dr. Shambat, and I also see a lot of senior faculty members, and of course, online participants. I compliment Dr. Imran Pasha for organizing this particular program. I think he just attended one of our curriculum conclave last just a few weeks back, which we had attended, and he was one of the very enthusiastic participants. So I think that outcome today is what is this particular, what is this FDP program, what he has organized. I think Dr. Nirgude, I think he already briefed us what is EPFs. I think in the curriculum conclave, I think I did make a statement that what has happened is, I think with this new curriculum, probably in the medical fraternity, they have implemented this curriculum, the CBMA, but the Dental Council of India is actually just a draft proposal. So I'm so happy to see that, colleges are already sensitizing their faculty. And this is definitely a good move. For example, when he said the EPFs, we have, I think the last time I learned so many acronyms, and today I think I have something which is called as competency by design, because we all talk about a competency based CBME, CBE. So these are different acronyms which is being used, and even in assessment methods, there are so many things. And I think the bottom line is, as Dr. Nirgude very rightly said, is the faculty. I think faculty development is very important. Unless that happens, if you have to implement any major changes in the curriculum, I think it's very important to have these FTB programs. And I'm so happy to see that, Enapa Dental College has taken it forward. And we have today, I think, a speaker, Dr. Andaleeb. From what I know is, I think in the Gulf medical colleges, definitely, I think this particular curriculum has matured. And I'm not definitely an expert. From what Dr. Nirgude said is, I think our curriculum is still in the delivery stage, and the Indian medical curriculum, I think, is in the infancy stage. So I think it's very good to have an expert who has probably gone through the complete cycle of this particular curriculum to give us inputs on what exactly it is. So I think I wish this particular workshop all the very best. Thank you so much.
Ma'am, thank you. I still remember fresh your speech on the day. Thanks a lot for giving and motivating everyone. And I think the only thing which is permanent is the change, as Sir said. We all have to adopt. We all have to change ourselves. We all have to learn the new things. And learning and relearning is a process, and it will happen through a slow process. And this faculty development is aimed at introduction of the words to all the faculties. Both online and offline attendees will benefit from it. Thank you, ma'am. Now I request the NFI Dental Education Unit and NFDC member, Dr. Vinita ma'am, to give the vote of thanks. Oh, I'm sorry. Now I request the Dean to give away a sapling as well as the memento to the chief guest of the day, Dr. Ashita Opur ma'am. Now I request Dr. Vinita ma'am to give the vote of thanks.
I deem it my pleasure to be proposing the vote of thanks for today. To begin with, I would like to thank all the statutory bodies of the NFI deemed to be university who have always supported us in all the endeavors which has been happening within the campus. Today, I extend my gratitude to our Dean, Dr. Akhtar Hussain, who has always been encouraging and for his constant support and always encouraging us to do all these programs. Thank you, sir. Dr. Ashita ma'am, who's always been there, almost most of our programs, which whenever we start something new, she's always there to encourage us. And since ma'am has already gone through this process, I thank you, ma'am, for being here today, taking out your time and being with us today. I would like to thank all our vice principals, Dr. Shambat sir, Dr. Chatra sir, and Dr. Maji ma'am for their constant support. Today's program wouldn't have been possible without the help from Dr. Abhay sir, our Deputy Director NFTC, who's always been encouraging and supporting us. Thank you, sir. Our guest speaker for the day, Dr. Arshdeep Andaleeb, has taken out his time from his busy schedule to be with us here today, share his knowledge, and I'm sure all of us will be benefited through this workshop. Thank you, sir. So I thank the IT department for their support in this hybrid mode today. All the members of NFTC and Dental Education Unit for all the support in the workshops being held today. Last but not the least, all the participants who are going to be benefited by this program. I thank one and all for having taken out the time to be here today with us. Thank you.
Yes. Now coming to the most important part, the introduction of the speaker, Dr. Arshdeep Dr. Andaleeb Arshad, who's the Director of Faculty of Development, Kuwait Institute of Medical Sciences, Specialization, Ministry of Health. I remember when I spoke to Sir and said, Sir, we want to have such program. Would you do the program? Sir was right ahead, come and tell, yes, I will be doing it. Sir, we thank you from the entire NFI deemed to be university, NFI Dental College, and all the statutory officers for agreeing and being part of the program. So without any further ado, I request you to take over. Thank you, sir.
Yeah, thank you, everyone. Good afternoon, and to all the dignitaries who are attending. Thank you so much for giving me the opportunity to speak to Yeni Poya University. It's such a pleasure, and perhaps it's the first time that I'm speaking to, a faculty in India. So today we are going to talk about competence by design. I have, as a medical educationist, I have spent some time with undergraduate medical colleges, and then right now I'm doing postgraduate. I'm dealing with postgraduate medical institution in Kuwait, which we are kind of like the Royal College in Kuwait. So we deal with the specialization training in Kuwait, right? We are very closely linked with the Royal College Canada. So many of our programs are getting accreditation with the Royal College Canada, which means that once our residents they finish training in Kuwait, they will be able to not only sit the exit exam, the specialization exit exam in Kuwait, but they can also go to Canada and sit the specialization exit exam, which the Royal College Canada offers. So so our training is kind of getting the equivalence, right? And one of the requirements is that since the Royal College of Canada has shifted to EPAs and competence by design, therefore, it is also required by our programs to shift to competence by design. Competence by design, even to Royal College Canada, is very new. They have been working for at least now a decade on developing these EPAs, which are now ready for most of the specializations. Royal College Canada deals with almost 60 specializations that they offer in Canada. And we in Kuwait, we offer almost 30 specializations, right? So many of my examples that I will be giving in this session will be coming from postgraduate specialization, but I will ensure that it becomes relevant to you also. So I will bring examples for dentistry also. And then from what I hear from, so the information that I got from Mr. Imran, Dr. Imran, was that there are doctors also attending, which is more relevant to them also. Good. This is Kuwait, right? A very nice view of Kuwait. You can look at the blue skies there. And then this is my institution, the Kuwait Institute for Medical Specializations. Today, what we are going to do is define EPAs and define milestones. And we are going to describe competency by design approach to learning and workplace-based assessment. We might also, as one of the dignitaries pointed out, that there is a thing called CBME, competence-based medical education. And then there is something called CBD, competence by design. So I will, in one of the slides, also go into the difference between them, if there is any. And we will explain the rationale for CBD. Why do we need competency by design? So let's here are some real life training issues that I usually start my slides with, that we see in our postgraduate training also, and also in undergraduate programs. For example, surgery in the final year in MBBS in the medical program, right? And then in surgery, we get residents who are failing the surgery final year MCQs only because of the reason that they lack core anatomical understanding. So anatomy was something that they have done and they have been doing throughout the 5 years. And then they are failing surgery because they do lack that core understanding of anatomy related to issues in surgery. In such a case, like I personally, I feel that it is not a student's fault, right? Or for example, in our postgraduate specialization programs, somebody is specializing in general surgery, right? And then we have this exam in the middle, which is more focused towards the basic sciences. And so there is an anatomy component in that part one exam, right? And then residents fail because of lack of core understanding of anatomy there. So these are residents who have done an MBBS, right? So 7 years of training there, and then they are in a residency program for the last 2 years. So kind of like 9 years in total. They have been dealing with anatomy, and all of a sudden, it's not actually all of a sudden, but the flags are always there, perhaps, but we were missing them. But now in an exam, they fail only because they're weak in anatomy. My question is that, my thing is that this is perhaps not a fault of the residents. It's actually a fault of the programs that are dealing with these residents or these learners, that over 5 years, you are not detecting it. Why were the detections absent in all those years, right? Another exam is that, for example, in dentistry, and of course you do anatomy, so you do anatomy in dentistry also. And so another example is that a resident is unable to, when it comes to an exit exam, for example, if somebody is specializing as a pediatrician, or somebody is specializing as endodontics, right? So we do offer endodontics program and different other dentistry specialization programs here at KIMS, right? And then they get failed in the exit OSCE. So they have been doing training for 5 years, and then they fail in the final exam only because of a reason that they are not able to do a proper examination. For example, here in this picture, it's kind of examination of the abdomen, but it could be in your case an examination of a condition related to dentistry, right? And they are not able to do a proper exam or a proper history taking during their OSCE. So the same reasons again. It is not that the student is weak. It's not only that the student could be weak, but perhaps we did not provide enough opportunities to the learner to learn a proper examination over the year. So he did not learn it during MBBS perhaps, and then he did not learn it in 5 years of training. So it's a very long time, right? A very long duration. So it is our failure as a faculty to not detect it and provide them the opportunity to learn, which is perhaps one of the reasons why we should actually be changing. So learning usually is judged by the time you spend as based on what the curriculum really currently is in different institutions. So if somebody, for example, finishes 6 months or a year in pediatrics, right? Somebody finishes a year in pediatrics, does it really mean that he has learned all of pediatrics? Or if two different pupils, are they learning the same amount in pediatrics? Plus, are they learning things that we actually want them to learn or not, right? So learning is right now just judged by the time spent. If they have spent a year, we get an impression that they have learned it, but we never get to know if they are actually really learning what we want them to learn, are they developing those competencies or not? And it's only in the exams that we go and check them, right? Perhaps during the rotation, during the duration, there are some formative assessments happening, but they are not contributing to our real detection of weaker students, right? So then there is a failure to fail also. We do not, especially when it comes to postgraduate specialization training, right? We do not want to fail our residents because we know that these residents after 4 years, after 3 years are going to be actually specialists with us, right? So for example, if somebody is an endodontist or an orthodontist, right? He knows that this very person after 2 years is going to be an orthodontist or an endodontist with me, right? So they do not want to fail that person in a rotation, right? Or perhaps they do not have the instruments to properly guide that person, right? And then what happens is that the only thing which is left is the exams. So the exams become high stake. The only barrier that remains is the exam. And it is also because we fail to fail is that we are only left with dichotomous judgments. Either we can pass them or fail them. There is nothing like in between. There is nothing in the gray area which we could tell them that, okay, you are very good, right? But only if you could learn these two more things, right, which are a weakness in you. If you could develop on these two things, you will be very fine. So since our curriculum perhaps is not identifying it, or perhaps even if it is listed there in the curriculum, it is not very practical enough to identify it, right? And our assessments are not tuned into identifying what is listed in the curriculum, right? Therefore, we are only left with either passing or failing them. There is nothing in between which we could offer them. And what residents always tell us is that there is little direct observation. So people who are involved in actually assessing in the end of a rotation are not those people who have been looking at them, who have been seeing them during their work in that rotation. So for example, if somebody is becoming, if somebody is doing a general dentistry specialization, right? And then that person and the general dentistry in our case is 2 years, right? And then there are rotations, there are 3 months rotation, there are 6 months rotation. And then we get to hear this thing a lot from residents, which is like, I was working with this and this very faculty, but when it came to the end of the rotation, my supervisor assessed me, and the supervisor actually never saw me working, right? So whatever the supervisor had was only secondary information and less direct observation. And with all of this, the only barrier for us to be safe for the society is that we are left with high stake exams. We have to make the exams difficult. We have to make the exams high stakes so the weak candidates do not go into the society and start practicing independently as a specialist. So now the Royal College has developed this spectrum, which is called the competence spectrum, right? So so they would say that learners are not like their competency is not a single a single point. It is kind of a spectrum which starts from being no voice, and then they become competent, right? And when they become competent on their activities, right, this is where you want to graduate them. And then the proficiency and expertise as a specialist or a consultant comes when they are doing their independent practice. So their point is that when you are trying to graduate a specialist, I'm talking about specialization programs, you want them to be competent in their specialty. You want them to be competent in the skills that are required to function as an independent specialist. And that is it. You don't want them to be proficient. You don't want them to be an expert. They will develop proficiency and expertise as they go through their independent practice as a specialist and a junior consultant and a senior consultant, right? So the point is that when they enter a training program, they are no voice, and then they become competent. Now, bringing this back and making it relevant to your dentistry undergraduate program, so you would say that you want them to be competent when they graduate from your dental college. When they graduate from your dental college, do you want them to be competent as a general dentist, not as an endodontist, not as an orthodontist, right? But you want actually them to be competent who could practice as a general dentist in the society, right? And you don't want them to be proficient. You don't want them to be expert. If somebody is proficient in some things, that is fine, right? But what we are looking for is for them to be safe and competent when they graduate from their undergraduate program that you people are offering. And when they enter, you know that they are just coming from high school, or perhaps they might have done a bachelor's, right? So they're just coming from high school. You know very well that they are no voice at this stage, right? Okay. Now, this is something that the Royal College has been based on the graph that I showed you. Now, they have developed for the postgraduate training program, which we also use at Kuwait, is that instead of, so earlier we used to call people as R1, year one resident. So for example, our residency training program, our specialization program is 5 years. So we used to call them R1, year one, R2, R3, R4, and R5, right? So the Royal College now says that instead of calling them as year one, year two, year three, year four, or five, let's give them names which have more meaning and which is more, contextual to EPAs that we are going to introduce in these durations, right? So then they would name them as transition to discipline, which is the first year, perhaps, right, in our case. So of course, now these are the fresh MDs or fresh dentists that we are taking, right? And then they are entering into specialization training. So we call them as transition to discipline, right? So for example, the discipline now is general dentistry, or the discipline now is advanced general dentistry, right? So they are now transiting to the discipline. So it could be 1 year. In some specialization training programs, it could be only 6 months. It all depends on how many EPAs you are putting there, right? So it all depends on how much you want to be covered. It could be only 3 months also. And then the next phase is foundations of discipline, right? And then the third phase is core of discipline. The Royal College, and this phase, the core of discipline, almost ends by the 4th year. The Royal College takes an exam here. And then, so their final exit exam, their final exam actually happens in the 4th year, and there is 1 year of training is still remaining. So they give their final exam, but they still keep on working, and they have still almost 1 year left to finish their training, right? So these are two different things for them. Exam is one thing, and then the training certification is another. And then these two both combine together and become a board, right? So then the transition to practice is what, like when you're going into continuing, going to your independent specialization practice. Before that, the year before that is transition to practice, because now you'll be independently practicing. Now, so the certification, the role of Royal College of course, kind of ends here, but of course they are involved in CMEs also. We at Kuwait Institute also are involved in CMEs, right? So that is the continuing professional development. The thing that the last graph was showing was that you become proficient. after being competent, you become proficient. And then, there will be years, for example, when you're 55 years of age, when you are 58 years of age, you start thinking of transitioning out of professional practice, right? So what do you do at that time? So that there will be that age also. Okay. Now, competence by design is an outcomes-based approach. So when I say outcomes-based approach here, I refer to competence-based medical education, right? So competency-based medical education is actually the theoretical foundation, right? So it's a theoretical foundation, it's an outcome-based approach. So, and it's based on competency. And then the way you design it, the way you design your curriculum for competency-based education is called competence by design. This is how the Royal College says, this is how we use this term. But of course, you could use it in ways that you want. But we have kept it a little, we have separated them a little, separated them. So we have the theoretical foundation is competence-based medical education, or the outcomes-based approach, right? And then the curriculum, which is designed for this approach, is called competence by design. And what does it use? It uses an organizing framework. In our case, it is CANMEDS. There is ACGME framework also, which is used in the UK, in US. And then, of course, the Royal Colleges in England, the UK, they have their own organizing framework. And this framework gives us the EPAs and the milestones, which are coming in the next slides. So theoretically, it is based on competencies, right? So that's the difference. Theoretically and ideally, if somebody, for example, there are 25 competencies that have to be covered, right? Let me give an example of 25 EPAs that have to be covered over the period of 5 years, right? Or in your dentistry program, in your undergraduate dentistry program, you in India perhaps decide that there are 32 EPAs that have to be covered, right? So you decided that there are 32 EPAs that they have to cover over a period of, if your program, say, for example, is 5 years, then the graduate dentistry program is 5 years, right? Now, what competency-based medical education tells us is that ideally, if they finish these 32 EPAs in 4 years instead of 5 years, they should be graduating, right? And so therefore, to make it more realistic and taking it out of the idealism and out of the educational theory, right? In real life, we have put it like this, that competency by design, you can finish it in 5 years, instead of 5 years, you can finish it in 3 years, but then you do have to spend the 5 years in full. So time is also a requirement in competency by design, right? So competencies learned and assessed are based on the abilities needed to practice. So it's not about what topics are there in your discipline. Topics don't matter anymore, right? In competency-based medical education, what is required for us to practice is more important, right? And those are listed. In this case, they are listed as EPAs. CANMEDS, many of you must have seen this. This is what the Royal College of Canada has developed like almost 25 years ago. I'm a part of the International Review Committee that reviews this CANMEDS. So recently, like 4 years ago, the Royal College did an international review, and I was the representative from Kuwait, right? So they keep on reviewing it almost every 5 to 7 years. So this is what they think we need as a medical expert. Medical expert is there only in the middle, which is like, things that are related. Somebody wants to be general surgeon, so things that a general surgeon does. But then they would say that even if you are doing general surgery, you always want to be a good leader. You always want to be a good collaborator. You always have to be a good communicator. So these are the other domains that are around it, right? So this CANMEDS actually, and then of course, communicator has 7 points of its own, collaborator has 10 points of its own, right? We call them competencies. in competency by design, we call them milestones, right? So all these things are listed there. They were always there for 25 years. So what the Royal College now has done is then taken them out and sorted them as EPAs, so that in each EPA we get to know which domains milestones are lying and how do they present in that very domain. So EPAs are entrustable professional activities, and this slide is also going to deal with milestones. So let me first quickly define EPAs. EPAs are the key tasks that an individual can be trusted to perform. And milestones are the observable marker of a person's ability, right? So milestones, as you can see in this graphic, is like milestones are kind of letters, right? Different milestones, they combine together, they form an EPA. And then in another EPA and in another key task, they would combine differently, and then so perhaps it might be the same milestones, perhaps it would be a combination of different other milestones combining and forming that very EPA, right? Okay, now here's an example. Managing cardiac arrest. Managing cardiac arrest can be a specialty-specific EPA. It could be an EPA, for example, emergency medicine. So anybody who is specializing in emergency medicine has to do this activity, right? When he comes to, when he actually becomes an emergency medicine specialist, he will be doing this thing in real life. So then he has to learn this in over the 5 years. So managing cardiac arrest can be a special, and then managing cardiac arrest could be an EPA for adult cardiology also. Managing cardiac arrest could be an EPA for internal medicine also, right? But then of course the complexity for each of these EPAs, the milestones for each of these EPAs in different programs will be different. So it is the milestones where the complexity come in, right? Okay, so managing cardiac arrest, what do you want? When they graduate as emergency medicine specialist, you want them to be competent enough to manage cardiac arrest to a level that you can trust them, that you can trust them, and therefore the word entrustment, right? And I'll show you how you check if you really trust the person or not, right? And then the milestones for such a for cardiac arrest EPA would be that he should be able to read the cardiac rhythm. So he should be able to read the ECG. He or she should be able to perform a proper CPR. He should be able to coordinate the arrest cart retrieval. So all the things of these sorts and many others also. So he should be able to communicate properly in such conditions when a patient has cardiac arrest. All those things combined together. So these are the milestones. And of course, if there is an EPA, for example, of cardiac failure, then many of the milestones, for example, ECG interpretation will come again in a patient of in a EPA of cardiac failure, right? And then CPR will also come there, right? But then cardiac failure will have their own milestones also. In your case, for example, managing performing a root canal, right? So if you are graduating someone as a general, specializing someone as a general dentist, right? Or perhaps an advanced general dentist, I don't know where, but perhaps in your program, it should be that he should be able to do a proper root canal, right? So, and then the milestones will be based on his or her ability to do a root canal. Okay, so how does it look like? This is an example of our surgical foundations transition to discipline. So surgical foundations are the first 2 years of a surgery program or any surgical program in which people are specializing, right? So this is the transition to discipline. Where is transition to discipline? Transition to discipline is this very phase, right? As soon as they enter the discipline. So this is the transition to discipline. So this is an EPA of transition to discipline, and the title is suturing in sessions. So the very good thing about this curriculum, this competency by design curriculum, is that it starts with the full assessment plan first. So before going into the milestones, it tells you how you're going to actually assess it, and assess it not only in the exam, you are going to assess it during the learning, during the training, right? So for example, if this is transition to discipline is, for example, in our case, 6 months. If transition to discipline is 6 months, right? That phase is 6 months. So they have to cover this EPA during those 6 months of the training, right? The first 6 months. And there might be 2 or 3 more EPAs during that time, right? So the assessment plan tells you very clearly that what is needed. You need a direct observation by a supervisor who has seen you doing a suture, right? And who could be a surgeon, a senior surgical assistant, a senior resident, or a fellow. So even residents could be involved in assessing the junior resident, right? And then it tells you which form to use. So in competency by design, what the Royal College has done is that they have developed 4 forms, 4 template forms, right? And then they get these template forms get customized to different TPAs. So there is form 1, form 2, form 3, form 4. They're coming, right, in the next slides. So form 1 is, so for this very EPA, you have to use form 1. This form collects information on the wound size. So the wound size should be less than or greater than 5 centimeter, right? And the setting, it also tells you where you have to do this workplace-based assessment. You have to do this workplace-based assessment in the clinical setting or in a simulation lab, right? So it always tells you if you have, you can do it in the wards, if you could do it in the outpatient clinic only, or just any clinical setting, it always tells you that, right? And then it tells you that you have to collect 2 observations of achievement. One, at least 1 wound in which the resident is suturing should be more than 5 centimeter long. In your cases, in the dentistry, of course, the sizes would be different, right? But you do suture sometimes during operations. So at least 1 wound should be greater than 5 centimeter. This is a requirement. And you have to collect 2 observations of achievement. So 2 form 1s have to be filled, right? And at least 1 observation in a clinical setting. So the other observation could be done in a simulation lab. And it asks you to, that this workplace-based assessment should be done by 2 different assessors. And these assessors could be a surgeon, a senior surgical assistant, a senior resident, or a fellow. Okay, so it tells you everything about the assessment. And this assessment plan is very specific to this very EPA. For another EPA, the assessment plan would be different. Okay, now look at the milestones which are related to suturing. So suturing is very basic, right? So the milestones are also not there a lot. So here, there were a couple of more milestones but then, these were the important ones which I'm listing here. So for example, the milestones here are milestone 3.4, and these 3.4, 3.4, this is kind of a coding which is coming from the organizing framework. So the organizing framework, as I told you, is CANMEDS. In CANMEDS, you saw that medical expert was in the middle. So all these things are related to the medical expert, right? Now, in another example, this is what I'm referring to. So the medical expert, the ME, is here. When there is a milestone related to communicator, it will show as C, and then, for example, it might be C 1.2, C 2.4, whatever. So that is how the mapping is there. Okay, now this is one example from pediatrics. So this is again transition to practice. Transition to practice is which phase? Transition to practice is this phase, the last phase of trading, right? And then they do the, once they finish transition to practice, they can go into practice independently as a specialist, right? Okay. So this one, leading discussions about goals of care. How do you yourself lead discussions? So because you are now kind of the senior most resident, and after a year or after 6 months, you will be actually practicing as a specialist yourself and leading different teams of care. So this is an EPA for leading discussions about goals of care. Assessment plan, again, it starts with the assessment plan. And it asks you that it should be a direct observation by the supervisor. So it cannot be an indirect observation. So, and then you have to use which form? Again, in this very case, you have to use form 1. Form 1, and then it tells you which setting. Again, in this case, it could be a clinical setting, it could be a simulation setting, right? How many observations are needed? Right, only 2 observations of achievements are needed, and no more than 1 in simulation. So one has to be in a clinical setting. Both could be in clinical setting, but you could go this way also, that 1 in a clinical setting and 1 in the simulation lab or in a simulation setting, right? So 2 observations of achievement, but these are very generous, right? Otherwise, there are many EPAs, for example, history taking, that EPA requires 20 observations. Right, so most of the EPAs, incidentally, the examples that I've taken are kind of like only 2 observations needed, right? But otherwise, there are EPAs that would require 20 observations. Now, what does it mean two observations only? 2 observations of achievement, which will mean that these are workplace-based assessment. One day, as a resident, if I feel, or as a learner, if I feel that I'm competent in this very EPA, I will go to my, for example, here it has to be a supervisor. So I will go to my supervisor and tell him that I feel I'm competent, right? So now both of us in our electronic portfolio, in our electronic portfolio, will open this very EPA, right? And I tell him that I would like to lead a discussion about goals of care. So I'll be brought into such a situation, and the supervisor will be sitting and observing me, right? And then the supervisor would tell me, well, I saw you, but I feel that you did not achieve it, right? Based on the milestones which I'll be showing, right? He would say that I feel that you were, weak in these 2 or 3 different milestones. So then the supervisor would say that we did the observation, we did a workplace-based assessment right now, but please come to me next time again. This would not be considered as an achieved observation. So you have to. So they have an infinite attempts, right? So the time is finite. Perhaps they only have a 1 year to finish 20 EPAs, or they only have a 1 year to finish the 5 EPAs which are there for the final year, right? Or for the transition to practice stage. But then they have infinite attempts. So then after a week, I can go back to the supervisor and say, I kind of feel ready. Can we do the meeting again, right? And then you would see me doing this EPA in a setting, right? And then you might say, okay, now you have achieved it, and you would put that in the portfolio. And this very EPA, look at the milestones. The milestones for this very EPA, leading discussions about goals of care, are something like this. The first milestone is medical expert 2.1, identifying patients with life-limiting conditions, including those for whom the burden of disease-modifying treatment or investigations might be greater than the clinical benefit. So there are the second one is also for medical expert, but the third one you could see is from the communicator domain, right? So that is a competency, or that is kind of a milestone coming from the communicator domain, right? Then you could see, okay, so all communicator and medical expert, but then there will be many, even here, I only brought 8 milestones. There were 2 or 3 more milestones for this very EPA, and there were two for leadership, which do not come here in this very slide, but there were things related to leadership also. So as you know, leadership is a domain in academics. Okay, so the key difference between EPAs and milestones is that EPAs are the tasks or activities that must be accomplished, and you have to ensure that you trust now on this very resident or this very student that when it comes to independently doing it, he will be able to do this task properly. So that task is an EPA, right? And since a lot of trust is involved while assessing that EPA, therefore it is called an entrustable professional activity. Whereas milestones are just the letters, are the abilities of the individual that help that individual to achieve that EPA. Okay, so in real life, it runs something like this, that from the very beginning, the residents or the students, right, in your case, the students, dental students, they will get their EPAs and milestones. As you said, the Indian Dental Council, they have developed kind of their milestones. So they have listed the competencies. Now it is up to them that they bring them as EPAs, right? So they sort them out. If they're all listed there, but then which milestone belongs to which EPA. So they have to identify the EPAs and then bring the milestones there, right? So the residents will, or the students will get all the EPAs and the milestones from the very beginning. And then there will be lots and lots of workplace-based assessments happening. And all these workplace-based assessments are going to be in the e-portfolios. And then there will be decisions. So for example, this competence committee, it meets every 6 months or it meets every 3 months, right? And then it looks at all the e-portfolios and sees, and then tells us that, okay, this very resident or this very student has completed his EPAs and now he can progress to the next stage when the time comes. He or she could progress to the next stage when the time comes, right? Or they could always tell that this very resident is or student is weak, right? And only 2 months are remaining. So he or she has to concentrate and finish. So it's a competence committee. Though the faculty is filling the form, right? The faculty is assessing them, but still it's a competence committee that decides. Okay, now coming back to the observation templates. As I told you, and as you saw in the examples also, they were using Form 1. Form 1 is a general observation form, right? Form 2 is more for procedural competencies. So for example, if you want to check someone doing a root canal properly or not, then perhaps Form 1 is not the right form. Then that very EPA, which is for a root canal surgery, will ask you to use Form 2. Or actually, if you're using the portfolio, it will present you Form 2 instead of presenting you Form 1, right? Form 3 is kind of a more of a multiple source feedback, very less used, very little EPAs use Form 3 and Form 4. Form 4 is a kind of a narrative observation. There could be something which is very, very specific to a resident or a learner. And then you just use Form 4 for that very specific. It might not be related to an EPA. It might be something which is very specific to that very learner. So you use Form 4 there. Now, in my examples, I'm going to show you, this is a Form 1, right? So this is a Form 1, which as I said, it is kind of for the general observation, right? Now here, you could see, and if we could take some questions also, I'd like to interact here, right? So what is the title of the EPA in this very form? Is it very clear? Is it very visible to all the participants in campus? What is the title of the EPA? And you people can write in the chat also, if you want to. Anyone? Which EPA is this Okay, this is form 2. Which EPA is this form assessing? So as you can see, this, yeah, anyone?
Um, I
Yeah,
think people are still confused about, I think you have told 4 general forms. I think we are still
yeah,
confused about, yes.
okay. Yeah, so this is form 2. This is an example of form 2, right? Okay, now let me show you here. So this is the form 2, which deals with procedural competencies, right? So this form is dealing with procedural competencies. Procedural competencies, for example, somebody doing suturing, that is a procedure, right? Or anything which is psychomotor, somebody doing a dental procedure. So in that case, we're using form 2. This form, as you could see, is assessing an EPA which deals with performing a lumbar puncture, right? So a lumbar puncture, this could be an EPA for emergency medicine. This could be an EPA for neurology programs. This could be an EPA for neurosurgery programs, right? So performing a lumbar puncture. In fact, performing a lumbar puncture could be an EPA for undergraduate medical programs also, right? So performing a lumbar puncture, this is what this form 2 is assessing. Now, which stage is this EPA falling? This EPA is falling at foundations of discipline stage, right? Where was the foundation of discipline stage? This is the second stage is the foundations of discipline stage, right? So this very EPA number 4 is falling at the foundations of discipline. So that also tells us that before this EPA, in the transition to discipline phase, the very first stage, residents might have done a maximum of just 3 EPAs, right? So this very phase, the transition to discipline phase, right, for neurosurgery, for example, there were only 3 EPAs, which they covered here. And when they came to this stage, the foundations of discipline in neurosurgery specialization training, this is the 4th EPA that they come. This is the 4th EPA that they are doing, which is performing a lumbar puncture. Now, that is all. And then, but the very good thing for this workplace-based assessment form is that, look at the scale. The scale doesn't range from poor to excellent. That is the thing. The scale is based on trust. The scale is not based on poor or good performance or excellent performance. The scale is based on trust, which says that based on, so they would see someone doing a lumbar puncture, or the supervisor would see someone doing a RCT, right? And then based on what they have observed the resident or the doctor doing, right? They would say, or the student doing, they would say that based on my overall observation, this is my level of trust. I had to do the procedure myself. So, which means that, this resident has just entered this stage, right? So I actually had to do the lumbar puncture myself, and the resident was just observing, right? So for a very early stage, for example, in transition to discipline, the very first phase, it could be very fine if the resident was just required to observe, right? Or you would say that, okay, the resident had observed doing a lumbar puncture for some time, and now this time he was actually doing it himself or herself. I had to just talk them through. So there were some steps that they kind of missing, and I had to, not some steps, actually I had to do this and then go to that step and that step. So I had to talk them through, and then he did the procedure. Now, and this is the higher level of trust, which is like you were not telling them the steps. They were actually doing the steps themselves, but then there were instances that you had to prompt, right? This is even more higher, which is I needed to be there just in case. So the whole lumbar puncture or the whole RCT was done by the resident himself or herself. You did not have to prompt, you did not, and he did it well and he did it fine. You were just there in case if any help is needed. So still, you do not trust him fully, right? The highest level of trust is that I didn't need to be there. That was all fine. I was so confident. I was very, very confident that even though I observed it, it requires a direct observation. I observed it, but my level of trust is that even if I was not there in the room, my resident would have done this procedure himself independently, right? So this level, I didn't need to be there, is something which EPAs falling in the last phase, the transition to practice phase, they require this level, right, for you to be satisfactory against this EPA. And of course, then the milestones are also listed, but the general rating scale, which is there on the top, the based on all observation overall, that actually is the decider. That decides if the observation has been sufficient or the observation has not been sufficient, they need to do the procedure again. And they have to come back for a workplace-based assessment. Okay. Now, what is the role of the competence committee? So the competence committees will review the learner's progress available in the e-portfolio. So as soon as you do an observation, you put the records in the e-portfolio, and then that tells the competence committee members that, okay, this person did 5 observations, out of which 2 are satisfactory. And then the competence committee would decide if this resident is now able to move to the next stage or not. So the point is that in competency by design, as we can see, learners are winning. There is a very clear learning path from the very beginning. I, as a student, or I, as a learner, know. And I can tell you that, for example, in the whole neurosurgery program, there are only 22 EPAs. In the whole family medicine program, for example, there are only 18 EPAs, right? So I, as a resident, I, as a student, know that I just have to cover in these very 5 years, just 18 EPAs, and that is it. So it's a very clear learning path for our learners. Then, which are in the form of EPAs and milestones, all listed from the very first day. And I also know that out of these 18, 3 will be covered in the first stage, 6 will be covered in the second stage, and then, as I progress, so I don't have to be, start worrying about everything from the very beginning, or I don't have to keep worrying about everything till the end. As I progress, I'll progress to a more complex EPA. And then it's very self-directed. So for example, there is an EPA on suturing, and then there is an EPA on history taking, right? And these are the 2 EPAs for these very, for my first stage, for example, right? I, as a learner, feel, I, as a student, feel that I would perform, or for example, history taking is more easier for me, right? So I would go for history taking EPA first, and that is fine. So there is a lot of flexibility. Today, I feel, for example, I'm in a good mood or in a better mood, right? And I would say, okay, let me do the challenge and let me go for the other EPA, right? Which is suturing, perhaps, for example. So I would do that EPA that day. So it's all very flexible. Whenever I, as a learner, feel ready, I would request my supervisor if you could observe it, and we could do the workplace-based assessment. So it's not that, there will be defined dates. No, there are no defined dates. Whenever you feel ready, you can go for it. And your attempts are kind of infinite, but don't, annoy your faculty. It's asking for so many attempts. And then there is always very frequent, meaningful feedback. So, and it's very easy for a faculty also to provide feedback. They would always say that, see, in this very EPA, you were good in 4 milestones, but this very milestone, which is related to communicator, you were a little weak there. So if you improve yourself on this very communicator milestone, you will be satisfactory next time. So you see how much is specific and how much meaningful the the feedback becomes. Because this thing telling a resident or a learner that you are good, you're excellent, actually means nothing. It actually means nothing to them, right? And then the competence committee decides. So the resident could, or the student would never say that, you know, this very person is, or this very supervisor, he doesn't like me a lot, and therefore, you know, I cannot progress. No. Whatever the supervisors are giving, whatever the senior residents are giving, they always go to a competence committee. And the competence committee has lots of flexibilities. They could always tell that, fine, you have covered we see all the satisfactory requirements that were needed, but we feel that you spend some time more on this EPA based on, you know, whatever history that is available in the portfolio. So it's a committee's decision, which is always very, you know, acceptable for residents as compared to one person deciding for them. So what we did today were we tried to define, we defined EPAs, we defined milestones. We described the competency by design approach to learning and workplace-based assessment. And we explained why competency by design and how does it help. So my slides finish here. Thank you very much. And I'm open to questions if there are any.
So thank you for this wonderful lecture where I think you have correctly defined, you know, the introduction, how it goes, the examples. My question is, when, you know, this DCI syllabus, that is the Dental Council of India, it is more or less, you know, seemed in this way only. But what would be your point? Because many of the faculty would say, look, I'm doing my traditional way. There is nothing wrong. It's been right from the last 60 years. Why do I need to change? Why do I need these 6 forms or the 4 forms? What does it do a difference? My doctor has become a principal of the college and is a very well-known surgical practitioner. Why do we require this? Now, I'm coming to this question because you know that, you know, we are coming through a change, you know, from last 80 years. I don't think so dental curriculum was reformed, and suddenly one day they decided, you know, we have to go to this. Now, how are we going to bring about this change? What are your key points? How would you tell, you know, we should take these baby steps?
Yeah. See, first of all, humans learn, right? And we are learning, even as educational psychologists, we know this thing, that we are learning how we learn, right? So we know how we learn, but then every other day, there is a theory coming up which tells you that, you know, this is a better way of learning, right? So, and then that is coming into practice. We are evolving all the time, right? And then, of course, the media, the devices are changing. So whatever suited, for example, 20 years from now, graduates that are going to be, say, for example, 5 years from now, they are coming from a very different generation. So they want to learn in different other ways, right? So things are changing in our life. So we have to match the industry. We could be the best programs, but still, when we look at the industry, their needs are different. So we have to match the industry, right? Or we have to match our learners. The learners that are joining our institutions, they think differently. So we have to match them. This is just like, you know, Harvard, when they introduced problem-based learning, Harvard was the top, right? Is the top in the university ranking. So the question was that, why do you want to shift to problem-based learning when you're already on the top? Because it's not only for the ranking thing, it's also because of our understanding of how we learn, our knowledge of how we learn has actually, you know, increased. And now we feel as educationists that this will actually help us more, right? So the generation is new, the generation that we are going to cater to actually perhaps, you know, needs more clear paths, and they are used to things which are, our generation is not into. The new generation which is coming perhaps is not into reading books that much, right? So all things of this sort, this is something which, and then of course competency by design, it was there, as you people said in the beginning also. We are doing these things whenever we are, for example, recruiting someone, as a very good example that was given earlier. When we are recruiting someone, we are checking as if we are going to trust this person as a practitioner or not, right? That is what we are. He might be very good in the content, he might be very knowledgeable, but then do we really trust him with the patients, right? So this competency by design is kind of, this curricular design is geared towards trust. So it is checking on trust. It is basing the EPAs on trust. Works more, but it will be, it will be perhaps 7 years from now that we will get to know if it is really, making a difference or not. The baby steps, as you asked, that was a very good question. The baby steps that you asked could be that, as I see now, your dental council, they have listed the competencies, right? But then perhaps, the examples that I showed you as EPAs, perhaps now they should be bringing those competencies and, classifying them as EPAs. So that work has to be done. When the council decides that these are the EPAs, which every dentistry institution in India has to cover, then, you see how much standardization there will be. All dentistry programs in India will be doing just 18 EPAs, for example. So everyone getting out from any college in India will actually be trained on those very EPAs. So much standardization. It took the Royal College almost 10 years to write those EPAs. So my point is that it could be only the universities at your end have to sit together and write it. One single university doing it for itself would not be, it requires a lot of courage to actually delete things. It requires a lot of courage to identify that, okay, this much curriculum is enough and that much is not. People online, they can also pose their questions online. I'm looking at the chat also. Okay, I think this is it. Thank you very much.
So,
Yeah.
so the next question for you would be, so what is can we use CanMed's the guidelines directly, or we need to take any approvals from them or the framework what you have used?
Yeah, so the thing is that CanMeds is for medical programs, right? And then, so perhaps you need to communicate with the Royal College of Dentistry in Canada. I know that because our dental colleges, our dentistry programs have also contacted them, but they do not have a framework ready yet. The CanMeds can be used as a dental framework, but the EPAs for dentistry with the Royal College of Dentistry in Canada is not ready yet. But then if you consult Royal Colleges in UK, I have a feeling that they have it ready. So it will be better for you to actually contact the Royal Colleges of Dentistry in UK and see, do some research and see whoever is using EPAs already, right? Contact them. in our case, for example, the Royal College of Canada is very open. This is all available open. They've made it open source. You just have to talk to them once and take their permission and start using it. You can do the same with Royal Colleges of Dentistry in UK.
Yes, sir. And did you face any difficulties when applying this change, or it was a gradual change?
So the trainings that we have been doing, our faculty, which my department, faculty development office does, is like for the last 3 years. So we're doing so many local training programs. We are doing training programs with the Royal College. Royal College Canada comes to us all the time, right? So it's for the last 3 years that we are training our faculty. We want our faculty to be ready before the implement. And then the second big thing is the support that you get from your higher ups. If the dean is willing, it will be a success story. The least resistance that we are expecting is from the least resistance is from residents. Actually, we have done it with the residents. The residents really wanted. What we hear from them in the training programs is that we really wanted to start very soon. Yes, so some programs have already started it, and then of course we have 35 programs. Many programs are planning to start it in 1 or 2 years.
So thank you. And I think our Dental Council of India, just to, for the information for all the faculties and for you as well, they have come up with something similar to this, but they have asked us to evolve ourselves, all these frameworks. And I think today's your talk on introduction on EPAs, I think it was so well, so simply it was structured. I feel anybody who's listening for the first time will definitely correlate directly and will be able to do some changes. As far as I see, already talks are going on within our, faculty. Just for thinking, they're trying to evolve some checklist, and I feel, it will be definitely a good go. But I really doubt, general forms and then procedural forms, form 1, form 2, form 3, form 4. There will be a lot of oppositions because, we have not yet changed our mindset. Probably through, when some circulatory or when regulatory authority says, you have to do it, definitely, all will be there for it and all will agree, yes, we have to do it.
Yeah, it will be way easier if it comes from the national authority, and it will be way, yeah. So for example, we are a national body in Kuwait, so it is so much easier for us to do it. And so you can write to also to the Royal College Canada. I can link you with them, right? So that even if it is not very relevant, but you can look at the whole EPA-based curriculum of different programs there. It will give you a meaning. It's kind of like the whole EPA program is only 50 pages PDF file, right? But I don't want to share it myself. I would link you to those people there. They are very willing to share it. You can see what your programs will also look like in the end when you have done it. But this is going to be at least 4 to 5 years journey.
Yes, sir. I can see the smile rightly. We are also, hoping that, all these things are. And thanks, sir, for the lead and, for the help. I'm definitely, I've already told that you will be there as part of the collaborator for us. And we look forward, to bring up a lot good changes in the field of dentistry through your help. And definitely medleads.com is going to lead the way through. So thank you. I wholeheartedly thank you. And the certificate of appreciation, we'll send it over the mail to you, sir. Thank you. Thank you very much, sir.
Thank you very much.